then we'll transition into our journal club to end the lab meeting. And I'll let Ariana take it. There she is. Take it over. Hello, and get us started.
Hello. Okay. Like Hannah, I am also technology challenged, so I'm going to just share the way that you shared. I really don't know there's another way. Okay. Can everyone see my screen?
Yes.
Okay, great. Okay, so hi everyone. I'm Ariana. I am a senior in my undergraduate studying biology. And I'm also the Federal Work Study Lab Research Lab Assistant. So I'm really excited to be sharing with you all and just presenting on this really interesting paper that I think is very applicable. So get started. So I'm going to move this really quickly. There we go. Our paper was cannabis legalization and cannabis-involved pregnancy hospitalizations in Colorado. And these are our authors there. So I'll jump right in. The objectives of this paper, there were two, which was to examine the trend over time in cannabis-involved hospitalizations with cannabis use diagnostics codes, which were ICD-9, and then it transitioned to ICD-10. And then also to determine the association between the density of recreational cannabis dispensaries at the county level and the prevalence of cannabis-involved hospitalizations of pregnant individuals, specifically in Colorado, which is where this study was looking at. And so there's a lot of significance, I think, to this paper now in our state, but in many other states. And so I just highlighted some three significant points, which was that first, that approximately 1 in 20 pregnant individuals in the United States report cannabis use during pregnancy at some time. And this is just from reporting, which is either self-reporting or being reported. So it could be an underrepresentation of the actual true numbers of individuals, as well as there's been an increase in the use of cannabis for self-treatment of pregnancy-related side effects such as vomiting and nausea, which the paper suggests in the first trimester for vomiting and nausea. And then lastly, a very good significance, a significant point about this paper was that although Colorado was the first state to legalize adult recreational use and sale of cannabis, now there's almost a third of US states that are have legalized recreational use as well as medicinal use of cannabis. So I think there's some great research that can be done and brought out of this. So the methods of this paper, it was a retrospective cohort study during the time period of January 1st of 2011 to December 31st of 2018. And they looked at two data sources for the retrospective study. They looked at the Colorado Hospital Association, which I'll just go by CHA for the remainder. And they also looked at the Colorado Department of Revenue, which the Colorado Department of Revenue was where it looked at the location and the names and the numbers of medicinal cannabis dispensaries within a county, as well as the recreational cannabis dispensaries. And they used two sources for assessing cannabis exposure within a county. And so their first was the number of recreational dispensaries per county per quarter. They arranged their data into quarters. And then also the relative size of the medical market within each county prior to legalization, which was in 2014, in the interaction with the main exposure variable. And so what they assessed for the medical market was the number of medical dispensaries within a county, but prior to the legalization of recreational cannabis use. And so this is a table in which it showed that what they did in order to categorize the counties was that if a county had 0 medical dispensaries within that county that it was at a no, they had no baseline medical exposure. And then if it had 1 to 9 medical dispensaries within that county, that it was at a low baseline. And then if it had 10 or more, it was at a high baseline of medical exposure. And to complete their statistical analysis, they conducted an uninterrupted time series analysis using Stata 16.1, and they used X-Poisson regression command to examine the trends between each county and looking at which counties had with baseline exposure and which did not. And so their results, they found that 6,229 pregnancy-related hospitalizations were concorded with cannabis that were reported to the Colorado Hospital Association, CHA. And they found that cannabis-involved pregnancy hospitalizations had more than doubled in the mean claims per county. As well as they found that counties with no baseline exposure to cannabis had more pregnancy claims co-coded with cannabis than counties with low or high levels of baseline exposure. And I didn't put that in the slides, but that was the original hypothesis, that counties who had no exposure would have a greater increase of cannabis-related pregnancy hospitalizations than counties that had low or high exposure at baseline. And so this was a table that represented their results. And I found some things really interesting within this table that the paper also mentioned, which was that the amount of medical dispensaries per county within Colorado had stayed relatively the same in its mean averages, with some actual years of decrease, like in 2018 to 2017, and then as well as just some small increases. And I found it interesting when comparing it to the amount of recreational dispensaries, as the recreational dispensaries did not start until in 2013 to 2014, when it was the legalization of the recreational dispensaries within Colorado. But we see from 2014 to 2015, almost doubling in the mean number of recreational dispensaries, which I thought that was just very interesting to show like the trajectory that had occurred in just a year, and that it's had a steady increase in the mean number of recreational dispensaries. And then in the, I guess this would be maybe the fifth line, you see that as I had mentioned, that the mean number of hospitalizations per county had doubled and almost tripled from 1.7 mean number to 4.7. And the greatest increase that was seen was between 2013 to 2015, with the numbers of pregnancy hospitalizations that involved that were related to cannabis use. And so this was also a graph of the paper, and on the left, you see the unadjusted numbers, and where it looked at each of the counties specific to Colorado that were either at baseline, had no medical exposure, had low or high medical exposure to cannabis. And what was really interesting was to see on the right, where you saw it adjusted for the per 10,000 births within a county, was just the fluctuation between the amounts of pregnancy hospitalizations that were related to cannabis use, that the counties that had no baseline had a greater influx of hospitalizations than the counties that had exposure at baseline. And so in the paper, it discussed a few things that were relevant to its research and also to related research that had been found. And they had, their findings were congruent with their original hypothesis. And they observed that there was an increase in the use of cannabis by pregnant individuals after the legalization of recreational cannabis in Colorado at 2014. And they also saw that there was a greater increase in the hospitalizations of pregnant individuals in relation to cannabis use within counties that did not have medical cannabis dispensaries prior to 2011. And then related research that they had included within the discussion had shared that the most common reasons for cannabis use among pregnant individuals were to self-treat for anxiety, nausea, and vomiting, and pain, or to relieve stress. And they also added within the discussion that there was a heightened concern for cannabis use during pregnancy due to its association with the risk for the mother and the child. And some risks that were associated with the mother were the risk for the use of using other substances along with cannabis, such as alcohol and tobacco. And for the child, they had noted that there were biological effects that could be shown, such as preterm delivery, decreased birth rate, as well as effects on childhood development, such as their neurodevelopment and their neurodevelopment. And then the discussion also emphasized the importance of identifying cannabis use during pregnancy that will allow for targeted interventions to be implemented. And so they emphasized that identification would be helpful in self-reporting. However, many individuals did not self-report due to stigma and fear of the stigma that comes along with reporting while being a pregnant individual. And so this study also had shared that it did have some limitations. The first being that it was only set in Colorado, which has the legalization of medical and recreational cannabis, but many states do not have this, so it's not exactly applicable for every US state. They also shared that there are variations in reporting to the Colorado Hospital Association. So some that may have been reported, say the later months of 2018, may not have actually been included in the study because they weren't officially reported to the CHA until 2019, so they might have been excluded. And then they also shared that a limitation of their study was that the study did not differentiate between the reasons for the cannabis, the reason for the hospitalization of the pregnant individual, and how their cannabis use was involved in their hospitalization. They didn't share the severity or look at the reasons behind their hospitalization. And then lastly, the study had shared that it is likely an underrepresentation of the total number of cannabis-related pregnancy hospitalizations due to cannabis use being reported to social services, that it may not have actually been the true number of reported cases. And so some conclusions of this study was that in Colorado, cannabis-involved pregnancy hospitalizations more than doubled between 2011 and 2018, with the highest increase occurring after the legalization of recreational cannabis in 2014. They also concluded that the number of recreational dispensaries is positively associated with cannabis-involved pregnancy hospitalizations, that it was a small positive association, but positive. And the last conclusion was that counties with no exposure to medical cannabis prior to 2011 had a greater increase in cannabis-related pregnancy hospitalizations during the study period than counties that had baseline exposure in 2011. And so I thought of some future work that could be accomplished maybe off of this study, would be incorporating the addition of medical record abstraction to determine how cannabis was related to the pregnant individual's hospitalization, as well as investigations on such risk factors that could be associated with cannabis use among pregnant and postpartum individuals. And that could serve at the individual, community, and societal levels. And then lastly, future work could be also working towards decreasing the stigma and other barriers that are present to reporting experienced by pregnant individuals who use cannabis during their pregnancy. And so that's the end of the presenting, and these are some discussion questions that we can talk about around this paper. And before we start on this, was there any, I would like to ask if there were any thoughts or anything that really stuck out in the paper from any of you that you want to share?
Thank you, Ariana. That was great. It was a great synopsis of the paper. You noticed kind of a lot of the similar things that I noticed when I was reading it. Thanks so much for the great presentation. I'll get us started. Actually, I was going to note what are some strengths of the study. And so I'll be curious what thoughts people have. But I was just impressed, just kind of from the get-go, that somehow they have this data set for all the hospitals in Colorado and they just can access it. I don't know. There wasn't a lot of information. I was like, where do I get that? So I like, and then it includes uninsured patients and insured. I think they said that at one time, if I remember correctly. And they were able to associate it to where people lived. So it had zip codes that they used to figure out where people live. So I thought that was the strength of the study there was, we just came off of the research and progress presentation about, our data, but it's, the biggest limitation is just from our hospital, right? But it's cohesive, it's comprehensive since it's abstracted data. But I thought that was one strength of the study, just to kind of get us going. But I'll like to hear anyone else's thoughts on the paper. I just put in the chat too, if your next question about how it can be applied to our state. So there's a website, it's called cannabis.virginia.gov, ironically. So if you ever get confused about what's legal in our state versus others, this website's pretty good and it kind of outlines it, because I get confused sometimes, like what happened last year, et cetera. But as most of us know, medical cannabis is legal, and then they decriminalize, small possession and be able to transfer small amounts of cannabis between people, but you can't sell it yet, right? So we're not what Colorado has. But I don't know this. I don't know if anyone else knows, but I do feel like we might see an increase in dispensaries for medical cannabis. And I know this paper, like you noticed, Ariana, that stayed constant in their study time frame. The number after legalization, it was about the same number of medical dispensaries. But I would just be curious, in a state like ours, where we're going to have a lot longer period without, quote, recreational cannabis coming down, since the House, poo-pooed that bill a few weeks ago. I wonder if we might see an increase. I'm not sure on this. I know Margie can probably speak anecdotally for what we see clinically, but I would just be curious to see if on a state level, if we might actually see a smaller, right, but still an increase as medical dispensaries increase. I don't know.
Yeah. Thank you for the presentation. It was really well done and nice. I also think this is like very interesting and highly relevant article. And it brought probably to mind more questions than, than statements or answers, but things that I thought was interesting. Well, for one, anecdotally, as Dr. Martin said, I have had not many, a handful of patients that have contacted me. And basically they were asking, they wanted to apply for the medical card to get marijuana legally, but they didn't want to do it if that was going to bar them from our clinic. And so I asked them why they wanted the card. You know, why did they want the marijuana? And they told me it was for anxiety. All of them at this point have told me it was for anxiety. And I did, and this particular paper brought that to mind again, that yes, a lot of these women apparently were taking it more in the first trimester for nausea and vomiting, but there was even a little slightly higher amount of people that said they were taking it for anxiety. And it made me wonder, are we not, are we under treating or not assessing to treat our women in the first trimester for anxiety? Especially because it was more people that were going, that were using or getting the marijuana after the recreational stuff opened, and that they suddenly, you had this group of people that could just get it or have a friend get it, and they're like, you know, I think I'm just going to try it instead of getting something for anxiety. I don't know. So the whole anxiety piece is something that came to mind, and what that means for us for the first trimester. So that was one thing I thought about.
I also was really interested in that piece about the self-treatment and how and why for anxiety as well as for the nausea and vomiting within the first trimester. I thought that was really interesting that those were some of the causes or that reported reasons for using cannabis within their pregnancy term. I thought it was really interesting for the self-treatment aspect of anxiety and pain, I think was mentioned as well.
I have a very probably ignorant question, but does cannabis have any like negative side effects in particular to pregnancy and or like the baby's health, either postpartum or like during development?
I'll have to answer that, but absolutely. Yeah. Yes. Dr.
Yeah.
Martin.
Yeah, well, as everyone knows, you can't do, like I say this all the time, you can't randomize people to things that are illegal. So we don't have trial data to show, but a lot of observational data shows a potential association between prenatal cannabis use, maybe some during lactation, that data is even less, and maybe some neurocognitive outcomes for infants as they grow up. But again, the data is all it's all observational. Historically has not done a great job about taking into consideration other factors, big ones, smoking, cigarettes. So a lot of but the observational data studies are kind of not consistently, completely showing a little bit of a low birth weight, a little bit of preterm birth, a little bit of neurobehavioral outcomes. But it kind of depends on how it's measured. Was it cannabis use before pregnancy recognition? Was it cannabis use later in pregnancy? So there's a lot of caveats to that, and it's very controversial in the world of substance use in pregnancy people, because the Surgeon General warning came out saying no level of cannabis use is healthy in pregnancy or breastfeeding. And they said that, but when they said that, there was not a lot of data to support what they were saying. I'm not saying people should smoke cannabis during pregnancy or lactation, but it's just our policy should be evidence-based, is what I should say. So yes, about the baby. Mom-wise, there's not a lot of observational data. People correct me because I don't read the cannabis literature ad nauseum all the time, but from my reading, not consistent associations with bad maternal effects of cannabis use in the perinatal period. However, cannabis use can sometimes cause something called like hyperemesis. So it's like a version of hyperemesis that people get in the first trimester or other parts in pregnancy where you just throw up all the time. It's a terrible thing. Like if you take care of patients during pregnancy, they just can't stop having nausea and vomiting. And cannabis use can cause that too in some patients. And you can also have cannabis withdrawal symptoms too, from when you have a dependence on cannabis. Obviously that withdrawal symptoms are different than they are for like opioids, alcohol, etc. But they can have withdrawal symptoms also. And just like with everything in pregnancy, everything's just worse when you're pregnant, right? You have a cold, it's worse if you're pregnant. So I was curious in reading this paper because our main outcome was these admissions to the hospital, right? Hospitalizations. And I know it's billing data, but there's no way to know why cannabis was co-coded on this hospitalization. Was it just because someone is using cannabis, or was it a cannabis specific issue? But with this data set, they're not able to dig into that. But that's what I was wondering was, gosh, what were these hospitalizations, right? That really, I mean, their graphs are like pretty impressive, right? Just that I know their regression wasn't that exciting, but their graphs showing the significant increase were interesting. But I was curious, like, are they seeing significantly more hospitalizations directly related to the cannabis use, or is it indirectly related, or just a positive screen? Again, it's unknown, but I'd be curious.
Yeah. I want to dovetail real quick, and then I'm going to put my mute button on. So I wonder on that note that Dr. Martin is talking about, if they had, with the recreational centers opening, okay, so now you've got people that perhaps are going to use marijuana that hadn't in the past, and they do say that people that are not familiar with marijuana and now are suddenly using marijuana, especially edibles, because they can take a while, that they take too much and then they get these panic attacks. And so they end up in the ER. So I think my question in that respect too is, when they say hospitalizations, does that just mean they went to the hospital, or is like they were inpatient, I mean, there's a lot of thought in this paper, things that you can dovetail off of in this paper that are very interesting, I think. But my mute button's going on.
No, I agree, Margie. I'm curious what these hospitalizations were too. I mean, we can all say anecdotally, right? What I've seen clinically is we do see the patients coming in, with the nausea and the hyperemesis related to cannabis use. We do see patients with cannabis withdrawal symptoms telling us about it, et cetera, like, the side effects that Margie was talking about. But on a statewide level, has there been an increase? I don't know. I can just speak about as a single provider. But I would say that, like, I saw these when I was in residency in North Carolina. I mean, I had patients there, and there was no legalization of anything when I was there. And so but I still saw patients that had all of these symptoms. Do I see them a little bit more now? Yes, but I also only work with substance use patients. So again, I can't really go off of my anecdotal experience.
Well, thank you both. I think that this paper, it does, like you were saying, Margie, as well, it has a lot of offshoots for improvement and just to get more like data on what were these individuals specifically coming in for. And I also think it didn't share, and I might have missed it, but it didn't share if it was repeated visits to the hospital by one individual. So that could have also created some differences as well. Did anyone have any other just points that stuck out, or we can try a question? Okay, I think I'll ask one of the questions. So one that I was really curious about was, where did I see it? I don't think it's up here, but I will ask, how might this inform our work and as the lab, and as well as in OB Motivate and for Virginia, and as we see a difference of, I guess, a difference in pregnant individuals. How might this paper inform our work?
I'm thinking since we don't have any dispensaries or anything here, we're comparable to the 0 level that you were mentioning from the paper. So we could expect some of those sharper increases in those type of hospitalization.
Yeah, that's a good point, Deshonda. The House did not pass the bill recently that would go to legalization of recreational cannabis. So it's kind of interesting because we're going to have data now from just medical cannabis, and being able to compare us to other states is an opportunity, I think, to answer your question, Ariana. I would also think too, we do a lot of survey research in the lab, and we can maybe start adding a little more detail about if someone's hospitalized and we're capturing their hospitalization, what was that hospitalization for? I think a lot of times we've said like yes or no related to substance use, but given the complexity of cannabis, its legal status and all that, maybe we need to start being a little more specific when we capture that variable of, is it cannabis or is it related to something else? Given that this is a moving target, and in order to keep our data as useful as things change going forward, it's better to get more information now so we can tweak it later on.
I was just thinking this would be a really cool opportunity to do some qualitative work as well, to try to understand motivations of cannabis use. Because I can think of a lot of reasons why someone might try to self-treat, so it would be fascinating to hear it from patients.
I definitely agree, Erin. I think it would give while we don't have recreational cannabis legalized, it would give an opportunity to somewhat be ahead of the game in a way, and looking at maybe motivations and risk factors and things like that. Definitely.
I know some investigators that have studies that are ongoing on that. So in other places. So yeah, I agree. That is very warranted work and fundable work that people are working on. I'll let Margie, do you have any thoughts on like clinically how this is kind of taking things home for you?
I think, so for those who aren't in the clinic, what we're doing as when we present marijuana, if it comes up, the patient tells you, or you're bringing it up with your urine, or, it comes up in different ways. We have a patient packet of information we give people as well. And marijuana happens to be in there, marijuana use in pregnancy. We do present it just like we present alcohol, that marijuana is legalized in, many states, and just like alcohol is legal, it's still not something that is recommended, by the professional, organization when you're pregnant. So we still bring that up in that way. Clinic-wise, I think what's interesting to me is policy. I guess you pointed out in the paper, or maybe it was somewhere there that it was, I think they were saying that there were the places that the dispensaries were saying it was a great use for nausea and vomiting. And I think there's even doulas and others that sell that. So I think that like messaging is going to be huge. And if there's no policy around that, then you're a dispensary with a business, and I guess you're going to put out the message that's bringing people in. So I think that's something for maybe the state. I don't know, messaging sounds just like it's going to be a big item here. Most people know alcohol use, can cause issues with the newborn. I don't know that most people would even recognize there could be again, I guess we got to get the evidence for that. But yeah. So now I think clinic-wise, we continue to, it is a substance. It is a substance that, we would prefer pregnant moms not use. They are advised by our pediatric team about breastfeeding, and we highly recommend breastfeeding for our moms. if they, don't have an active like use substance right then. But with marijuana, they have to sign a contract, and so yeah. I think that's about it. Did I miss anything, Dr. Martin?
No, I think that's right. We talked to them about what we should talk to them about with the risks about it. We go over that we do assess why they are taking it, I tell them like, hey, I hear you, and I'm not trying to say you're wrong, but it's my job just to let you know like what the research shows and what we say. And, cannabis use does not improve long-term mental health outcomes, right? In the moment, it might help you short-term, but it does not have long-term evidence to show its benefit. And then we do talk to them about how you can develop a dependence and addiction on it. And all of our patients already have an addiction, they don't want another one. So we do talk to them about that too, about the risks too, just for their overall health. And some patients, we counsel them and they know, and they continue using it. And so we don't kick people out of treatment for that, because that'd be silly. But we just continue as providers to continue to assess to make sure they're not going from substance use to substance use disorder. So we continue to do that, just reassess constantly for evidence of a use disorder, because that's the problem that we would need to make sure that we definitely address, especially when you're an addiction provider and you can do that. Yeah, and Deshanda's comment in the chat, I think, is a good one. And I mean, I go in soapboxes all the time about legalization of marijuana and then public health messaging. And I think you are completely right, Shonda, that people become more comfortable talking about it. But I don't think public health messaging has been on par with our messaging in general, right? Of people talking about it. So then who have organizations that have money, i.e. the marijuana industry, are the ones whose voices get louder, because we haven't been putting as much into the public health sphere as we should. Yeah. So I feel like they should be in parallel, but they're not. So we're comfortable talking about it and we can bring it up in conversation, but we don't have that public health messaging like Margie was talking about with alcohol, which I think we should. Oh, I'll say one last thing before we end. So I went on a tour of the Greenleaf dispensary last year on my birthday. It just happened to be on my birthday, and I was like, oh, this is the best birthday present for the addiction doctor. I didn't tell him I was an addiction doctor when I went on the tour. It was a tour for doctors. And I got to the end of the tour and I was like, oh, this is the best part. And I went up to the pharmacist and I just asked, because in the state of Virginia, at these medical dispensaries, they have to have a pharmacist that's licensed by the state of Virginia there. And so I was talking to this pharmacist. She was real nice and chit chatted. And then my first question was about pregnant people, and was like, what do you talk to them at all about, how there's a Surgeon General's warning against cannabis in pregnancy? And then she essentially told me, we just let it go. She just said they don't talk to them at all about, and there's no risk benefit discussion at all. They just let it keep going. And then I said, oh, I'm an obstetrician. She was like, oh, whoops. So that was sad when I heard that. I was like, okay, great. So you're just giving this out and not giving any type of counseling at all about the potential impacts of this. And then I asked, well, what about patients who are using cannabis and maybe are at risk, or showing risk factors for an addiction, right? Going to a cannabis use disorder, what do you do about that? Do you guys regularly reassess patients for adverse, continued use despite adverse consequences? And then she said, no. And she bounced around the issue. And then I said, so you're essentially telling me you guys don't assess for that at all. If someone has a cannabis use disorder, you just keep on giving it out. And she said, yeah, you're right. And then I said, I'm an addiction doctor too. She said, oh, great. So I'm really concerned about, what is happening. And so again, this was my N of 1 interaction with one pharmacist at this one dispensary, but I think it's a one example that reflects the lack of public health messaging, that the imbalance between a public health messaging and messaging that patients are hearing and seeing in the news, and even from their own pharmacists potentially at the dispensary, that's not on par with one another. So if you can get a tour of the dispensary, it was quite fun to kind of see how it works. It was interesting otherwise. Any other comments, questions, etc.? Okay, well, thank you, Ariana, for leading us in our journal club. Thanks for letting me go on my tangent at the end.
Thank you.
Thank you, Ariana.
Yay, great. Well, thanks everyone for coming.